Breast cancer is the most commonly diagnosed malignancy in the United States, and it's the second leading cause of death from cancer among females. For women between the ages of 40 to 55, it is actually the leading cause of mortality. Approximately 1 in 8 women in the United States will develop breast cancer during her lifetime, and that would be about 13% of all the different women you know, whether that's your mother, daughter, aunt, wife. And according to the American Cancer Society, the good news is that breast cancer death rates have actually declined 42% from 1989 to 2021. This progress is attributed to improvements in early detection and in treatments. The most important factor for the development of breast cancer is actually going to be age. The risk increases steadily during a woman's reproductive years, and then it somewhat slows down. The incident rates then peak again between the ages of 75 to 79. Prolonged exposure to estrogen is important in the development of breast cancer. Factors that increase exposure are going to increase your risk. So some of those factors are going to include early onset menses, older ages during your first pregnancy, and delayed menopause. Early or use of oral contraceptives is also associated with a very slight risk. And that risk then dissipates rapidly with the cessation of those medications. Hormone replacement therapy also shows similar increases and a similar reduction in the risk when that medication is stopped. The diminished use of hormonal therapy is actually thought to be a major factor in the reduction of incident rates for breast cancer in recent years. A positive family history is a well-recognized risk factor for breast cancer. About half of the women with breast cancer have at least one relative of any type with the disease, and about 10 to 20% have a first or second degree relative that's been affected, meaning like their mother or their sister. The risk clearly increases with the number of affected relatives and with the age at which those relatives develop the disease. The risk for the development of cancer is highest for the first degree relatives of an individual with earlier premenopausal onset of a bilateral disease there. About 5% of women with breast cancer have a single gene mutation that places them at a higher risk. The two genes whose mutations are associated with breast cancer development are known as the BRCA1 or the BRCA2. You'll also hear people call it BRCA1 or BRCA2. These mutations increase the lifetime risk of breast cancer by about 50 to 85%. They also significantly increase the risk of ovarian cancer as well as some other tumors. However, what's interesting is that BRCA mutation only accounts for about 30 to 40% of all familial breast cancer syndromes. Other leading factors are going to be some of the obvious smoking, obesity, and not getting enough exercise. So when underwriting breast cancer, we're going to be looking at the different types, and breast cancer can develop in different parts of the breast. Cancers that arise in the milk ducts are called ductal carcinomas, and they represent the majority of the breast cancer cases that we see. Cancers that form in the breast lobules are known as a lobular carcinoma, and they're more likely than the ductal carcinoma to be present in both of the breast and spread bilaterally. The majority, or about 80% of breast cancers that are diagnosed, are going to be considered invasive lesions, and the remaining 20% are called in situ lesions. And these have cells that are showing malignant changes, but they've not invaded through any of the basement membranes. Now, with in situ, there are two different types of in situ carcinomas. There's ductal and lobular. The ductal type, also known as DCIS, is by far the most common. Like I said, this accounts for approximately 88% of in situ lesions. The diagnosis of DCIS is easily made by mammography, by the classical findings of just clustered microcalcifications. Although that mortality risk from these tumors is small, DCIS is important from a clinical and an underwriting perspective because it's a true precursor lesion. The primary lesion has the ability to reoccur if it's not treated appropriately. About half of DCIS tumors that do reoccur will do so as an invasive cancer. Lobular carcinoma, on the other hand, is most often an incidental finding. It's not usually detected by mammography. It tends to occur in younger women, and it shows diffuse involvement in both breasts. It's not really a precursor lesion, and it doesn't progress into an invasive disease. Its clinical and underwriting significance really lies in the fact that these are a marker for an increased risk of developing an invasive cancer later. The majority of those invasive cancers will be ductal, and the presence of LCIS increases the lifetime risk of an invasive cancer by 12 times that of a normal woman. Um, and these invasive cancers or these tumors, they can occur 15 years or more after the diagnosis of that original in situ lesion. So, when you have somebody that they tell you it was an early staging grade and found early on, they're going to be looking at whether this was lobular or ductal and what it means long term. So most invasive cancers are going to be considered adenocarcinomas. The most common, like 85%, is going to be an invasive ductal carcinoma. The most common histological type, or the next most common, is going to be the invasive lobular carcinoma. That tends to be a little bit more multicentric and to have an increased risk of bilateral disease. There are several other subtypes that may occur with much lower frequency. Some of those are known as papillary, colloid, muconeous tumors, tubular carcinomas. Those are relatively indolent in character and they carry a very favorable long-term prognosis. So we don't worry quite as much about those. Now, as far as diagnosis goes, most breast cancers are actually asymptomatic at diagnosis, meaning that women don't have any signs or symptoms at all that there's something going on. Um, the disease is occasionally noted by the applicant themselves on self-examination. They may notice a palpable lump or a nodule. They also may notice new skin or nipple changes. They could notice changes in the size or the shape of their breast, a bloody discharge, or lymph node enlargement. And sometimes breast pain. That's one of those things, though, that is actually very uncommon. A lot of women don't report any of these symptoms. They just find out through some kind of diagnostic tool that they're now a carrier. Clinical breast examinations do sometimes detect tumors as well. The primary means of diagnosis, though, is going to be mammography. Mammography uses low-dose X-rays to visualize the structure of the breast, and it's going to detect about 80 to 90% of the breast cancers that are asymptomatic in women. Findings that are suggestive of cancer are typically microcalcifications that they see in the imaging, or nodules or masses. Sometimes if a woman has dense breast or prior surgeries, the presence of implants, this can reduce the sensitivity to mammography. And so there are other ways to keep track of things. But so not all tumors are going to be detected by mammography. But with that being said, if there's something suspicious, a physical finding that an applicant is concerned about, that should definitely not be ignored, even if the mammograms are clear. Ultrasound examinations are also used to evaluate. This is usually used to evaluate suspicious lesions that are seen on the mammograms. Its primary value is that it can differentiate cyst from solid lesions, and it can differentiate lymph nodes from nodules. It can also be used to direct needles during biopsies and during cyst drainage. Because ultrasounds don't really visualize those microcalcifications, they are not an effective screening tool. So that's why we don't see them used very often, at your annual exams. They're just used usually if there's something suspicious. The MRI is more sensitive than mammography, and so sometimes you'll see that used. It's recommended for women with dense breast, again, for breast implants, or individuals with a high risk for developing breast cancer, such as those that are known carriers of that BRCA1 or BRCA2 gene. And then anyone who's had prior chest radiation, that's another situation where they are probably going to want to do an MRI and not just a mammogram. The disadvantages of the MRI, however, are that it has a very high false positive rate and it's expensive. Let's see here. So next we're going to look at how they stage the cancer once it's been diagnosed. In breast cancer, the stage is going to be based on the size and the location of the primary tumor, the spread of the cancer to any nearby lymph nodes or any other parts of the body. They're going to look at the tumor grade, and they're going to look at whether certain biomarkers are present. So the staging relies on the TNM system, which if you've sat in on any of my other webinars, you may have heard me mention that before. The T represents the size and the local extent of the tumor. The N is going to represent the nodal status, and it can be evaluated both clinically or pathologically. The pathological designation is the more accurate and preferred for underwriting purposes. This is usually going to be like N0, which would be no nodal involvement, or it could be N1, which means there was 1 to 3 positive nodes, and then it just continues to go up there. There are additional N subcategories that could be used to define the extent of the involvement, but we're not going to dig quite that deep. And then the M is a designation that indicates whether or not there has been any distant metastasis. We hope that that would be a 0. We don't want to see that it's spread anywhere. The other option is that it will be an M1, which means the cancer has gone elsewhere. The grading system is used to describe how quickly a breast tumor is likely to grow and spread. So that'll be the next thing they give us. And then the path reports will also show the biomarker testing. And with the biomarker testing, that's basically just used to find out whether or not the breast cancer cells have certain receptors, and we'll get more into that down the road here too. But basically with the TNM system, the grading system, and the biomarker status, they take all those, they combine them together, and that is how they come up with your breast cancer stage and grade. Next thing we want to talk about is going to be treatment. So the treatment for DCIS is directed primarily at preventing any kind of local reoccurrence. It generally is going to involve either a lumpectomy or with local radiation or a mastectomy. For LCIS, the treatment of the local tumor is not necessary as much as that lesion actually doesn't progress. The focus instead for LCIS is going to be on preventing the development of other invasive cancers. So with that goal in mind, the usual approach is either mastectomy or chemoprevention, using some hormonal therapy with SERMs, like tamoxifen is one you may have heard of often, or any one of the other new aromatase inhibitor drugs. So most of our invasive cancers of the breast can now be treated with just a lumpectomy. Usually that combined with radiation therapy is enough. Individuals with larger tumors or with an extensive intraductal component, or someone with if that lumpectomy is going to give an unacceptable cosmetic result, then they may require a mastectomy. That's the few times that they change from lumpectomy to mastectomy. Long-term studies have shown that the outcomes in terms of survival are actually equivalent whether you do a mastectomy or lumpectomy with radiation. For small tumors with adequate surgical margins and no lymphovascular invasion or extensive intraductal components, radiation therapy may not even be necessary. The major advance in the treatment of breast cancer in recent years has really been the use of adjuvant chemo and/or hormonal therapy after surgery. In general, the relative risk of mortality is going to be higher for those who do not receive some kind of adjuvant therapy there. Some of the things that we do want to keep in mind when it comes to treatment, there's a lot of factors that are taken into consideration. And so, a few highlights that I found: the benefit of chemotherapy is actually greater in younger individuals and in individuals that have a higher grade tumor. Chemotherapy has actually a very limited benefit in postmenopausal individuals, and it has a very little benefit for preventing tumor development in the uninfected breast. Whereas if someone's using tamoxifen, that's going to reduce the development of tumors in the opposite breast by at least 30%. So not all cancers are created equally, and not all treatments are created equally. So, if you've had somebody with that history and they were able to easily get a standard rating, just always keep in mind that no two cancers are the same and no two patients are the same. A lot of these factors come into play. Um, a relatively new development in the treatment of breast cancer has been the use of these aromatase inhibitor drugs. You may have heard of Arimidex. That's one of the most commons. This is used only in the postmenopausal setting. This drug basically, it blocks the enzyme aromatase in the adrenal glands and in the breast tumors themselves. It basically cuts off the supply of that hormone to the cancer, no longer allowing it to grow. These inhibitors are a first-line therapy for metastatic disease once it's spread, and they have been proven to be as good or better than that tamoxifen in the adjuvant setting, the one that increased our improvements by 30%. In addition, they are also superior a lot of times to preventing disease in the opposite breast. So mortality clearly varies with three major prognostic factors: the lymph node status and whether or not cancer has spread there, the tumor size and grade, well, the size and the grade. The effect can be seen in all of the age groups and over a range of durations out to 20 years or more. And for any given category, the relative mortality is always going to be higher in younger women, unfortunately. Survival is best with a history of a small, node negative, well differentiated tumors, especially in older individuals. As lesions get larger, more undifferentiated, or especially if they develop lymph node metastasizing, the mortality risk is going to increase steadily there. The mortality risk associated with breast cancer can actually extend out many years after the original diagnosis. Most of the excess mortality, though, has not been due to breast cancer itself, but actually to it metastasizing to other areas, um, and to cardiovascular disease that comes as a side effect as well. Especially with the use of some of the older radiation techniques, the methods today are definitely a lot safer. Um, with earlier diagnoses taking place and more modern treatment techniques, especially those adjuvant therapies, the long-term survival has steadily improved over time. Nevertheless, it still remains substantial in many risk groups, so there's that. Most reoccurrences with breast cancer will occur within the first few years after diagnosis. So you'll take note as we talk about these cases, we always need to know the diagnosis date and the remission date. Many of you have probably heard there's a 5-year postponement period. Um, and that is why, because most breast cancers reoccur within the first few years. The highest mortality rates are in those first 5 years after onset. However, the risk of reoccurrence can extend out for many, many years to be 10, 20, or more. The timing of reoccurrence really varies with the size of the tumor, usually occurring sooner with larger tumors. Poorly differentiated tumors tend to reoccur more rapidly after diagnosis and consequently have a higher short-term mortality. However, for those who survive the first 10 years, the outlook is similar to those with a low-grade lesion. So also something to keep in mind. Survival patterns by stage in men are comparable to those in women. However, because the disease is less common in men, the index of clinical suspicion is much lower and the diagnosis is often delayed. So overall, males do tend to do worse with the disease, primarily because the cancer is further advanced by the time it's diagnosed. So when it comes to underwriting, the first thing we're going to look for is an APS. They are going to want the original records with all the current follow-ups. We're going to want to see a full pathology report, current blood profile, and any follow-up testing that's been done, specifically mammograms, but also ultrasounds, blood test, anything else they've done. There is a specific blood test with the tumor marker. It's called the CEA. That is one that if it's been done, they're going to want to see those results. So when it comes to actually underwriting this, they're going to look at the stage and the grade. Obviously, they're going to look at lymph node involvement to see if it's spread, and they're going to look to see if there's any indication of recurrence here. Oftentimes, if there is a situation where recurrence has taken place, we're going to see declines on that. Not always, but oftentimes. For quick quoting purposes, if we want to shop these out and find our best carrier, we're going to need all the basic, the age, the build, the smoking status, all the regular stuff. And then we're also going to need the exact date of diagnosis with the stage and the grade, and the remission date. When speaking with underwriting and you hear things like a 5-year postpone or a 7-year postpone, that postpone is going to be based on the remission date, not the diagnosis date. So that's just something else to kind of keep in mind there. They're going to want to know the names of any meds that were taken along with the dates, any treatment at all, whether that's radiation or chemo. They'll want to know the start date and the end dates on those. Those are key to determining when coverage will be possible. So when it comes to how they're going to rate these, what we typically see is that stage 0, also again called in situ, is going to be standard at best, typically. I've never seen better than standard on a breast cancer case, unless there's been some kind of crediting program that's, something the carriers are trying to toy with, but 99.99999% of the time, you're not going to see better than standard on any kind of history here. With invasive carcinomas, the ratings are going to assume that the lymph nodes have been examined and biopsied or dissected. And if they haven't been, if there's been no biopsy or dissection done there, then this is likely going to be RMD or review by the medical director, which 99.999% of the time they're going to postpone until you've had that done. It would be very odd, I think, to see an offer without that being available. So in this chart here, what you'll see is as the tumor size grows, your postponement period here increases. What you'll also notice, or that I found interesting, is that in the older ages, your postponement time actually decreases. Again, because there's a better prognosis in the older ages than there are in the younger ages. So in your younger ages, you're going to see them postpone longer, and you're also going to see higher flat extras that last longer when it's diagnosed younger. Anything that has been is noted as an extensive disease or does show metastasis is typically going to be a postpone for about 10 years. And then after that, it will usually need to be reviewed by a medical director for approval. It's not usually something that your typical underwriter will be able to sign off on. It should also be noted too that in breast cancer, if a proposed insured has that BRCA1 or BRCA2 gene, it will be rated as poorly differentiated when we're looking at these here under this well-differentiated part. So that's also just something to keep in mind. Is again, there's just so many factors that go into it. No two cases are ever going to be the same. So let's jump into a couple cases here that we've seen just recently. Our first one was a female, age 75, born in 49. She was a non-smoker. She was originally diagnosed with breast cancer in 2005. She had a lumpectomy in 2006 and did 1 round of chemo. She's on no current meds. It was stage 0, so that's wonderful. It's best case scenario right there. They did test 1 lymph node. There was no cancer detected. But then in 2007, they found a second lump. So she had a double mastectomy with chemo and radiation. She had no issues since. She was placed on a pill for 5 years for maintenance. I would imagine it was probably one of those adjuvant therapies like that tamoxifen that we discussed earlier. Her last mammogram was over 10 years ago. It was all clear. The doctor said she needed no additional testing. Obviously, the doctors quit doing the mammograms due to her age, and the carriers were fine with that. We did have 2 carriers decline. We also had 3 carriers that were going to require this go in front of a medical director due to the fact that there was reoccurrence. But we had 4 carriers that offered it standard, and that right there is key to why we shop these out. Every carrier is going to look at this different. They all use different reinsurance guides, and some have some of their own proprietary guidelines. So we like to shop these in advance to make sure we go the right spot. Case number 2. This young lady was born in 1950, so that puts her at 74, also a non-smoker. Her breast cancer was diagnosed in January of 2017. She treated it right away with a mastectomy, radiation, and chemo. The last treatment date was October of 2017, and she did not have to do any adjuvant therapy afterwards. There are no current meds. There's nothing else for her to do at this point. However, hers was stage 3. The grade was unknown when we shopped this out, and she did have lymph node involvement. There were 3 nodes that were involved there. There is no evidence of reoccurrence. Her last mammogram was in just the spring of 2023, and it was normal. All of our carriers declined except for 1. That 1 carrier who was able to offer has their own proprietary guidelines. Sorry, I can't talk today. And they were actually able to offer standard with a flat extra of $12 for 4 years. And then after that 4 years, a permanent flat extra of $5 per thousand. So as you can see, very different situation. The staging was different, the treatment was different, and the outcome was very, very different. And with case example 3, this young lady was born in 1953, also a non-smoker. Breast cancer was discovered in her left breast in 2011, and then it reoccurred in her right breast in 2018. Both times were stage 0 with no lymph node involvement and no evidence of any reoccurrence. Treatment was tumor removal and radiation. The treatment was completed 30 days after the tumor removal. Her last mammogram was in October of 2023 and was normal. We did have one carrier that came in table B. We had another one that offered standard, which was very impressive, and all other carriers did decline or postpone or indicated it would need to go to the medical director for review. So again, just highlighting how different the outcome can be on each of these and the importance of shopping those in advance to make sure that we go to the right carrier the first time and don't waste your time or your clients with a carrier that's not going to give them a shot here. So let's see, some of the best practices are going to be thorough documentation for our review. If there is any possibility that your client is able to send us those medical records, I am happy to review those and summarize the findings and reach out to the carriers and find out who our best offer is going to be with. If they can't get their full documentation, a lot of times you can get the staging and the grade and all the pathology off of the agent or the patient portals. So do keep that in mind as well as you're talking to your clients. Again, prognosis is really going to depend on that tumor size, the grade, and the lymph node status. Lymph node status meaning whether or not it's spread to the nearby lymph nodes. One other thing I do want to point out too that I didn't put on here is with lymph node enlargement, something we've seen a lot of since the onset of COVID and COVID vaccinations has been the fact that they tend to become enlarged during women's monthly cycles and has prompted a lot of extra testing and mammography in women that are concerned that this is a symptom of breast cancer, and we found it not to be, but it is something to keep in mind. If you've got a client who had an enlarged lymph node or something and they're keeping an eye on that, and they've done the mammogram and everything's fine, and now they've got follow-up ultrasounds to really make sure, just know that that's really very common right now and not necessarily going to be a negative outcome. And of course, we will work with our carriers to figure out who is going to give us the best offer, both before an application is submitted and also during the process. Anything we can do to push that through, we are going to assist with. Other ways that IAMS is able to help is we do have amazing fact finders available on our website. They are just very generic health screening questionnaires that cover a little bit of everything. We do also have very specific questionnaires out on our website in our nail guide. That there's one specifically for breast cancer along with many, many other cancers. So if you would like a copy of these, you can visit our website at iamsinc.com or give your sales director a call, give me a call, and we have those and can send those to you. We are also here as a reminder to pre-screen any of those. You can reach out directly to me at Andrea@iamsinc.com to discuss the history. You can also email, or I'm sorry, you can email our pre-screen box, which is prescreen@iamsinc.com. Either is fine. You can give me a call, 800-255-5055, and just ask for Andrea. And we will do whatever we can to find a home for these cases. Definitely encourage you to use those health questionnaires, whether it be for something specific or just pre-screening in general. And again, don't forget to follow and like us on Facebook and LinkedIn. That is where you will find a lot of this information as well. I sure appreciate everybody joining us today and hope you have a wonderful afternoon. Please don't hesitate to call with any questions. Thanks so much.